The treatment of acne as a strategy to improve contraceptive adherence in Colombian young women. What I am about to present is the result of a research developed in a Colombian university, Santiago de Cali University. This work was conceived in the University Health Welfare Service that I am privileged to coordinate. I am a physician, and for 20 years I have had the opportunity, along with the help of brilliant people, of creating a sexual health promotion strategy aimed at offering high-quality information using open and sincere language. This strategy has been focused on the population more vulnerable to risky sexual behaviors, young people. Through this strategy, we wanted them to make right decisions regarding their sexual health and avoid exposure to sexually transmitted infections and unwanted pregnancies. We have called this program Hablemos a Calzón Quitao, which is a Colombian idiom meaning "let's talk turkey," or simply being sincere and open. Colombia is a 45 million inhabitant country. Geographically, we are privileged since we have 2 oceans and 3 mountain ranges that meet at the south of the country, which is the beginning of the Andes in South America. Because of our location, we enjoy a great diversity in flora and fauna, since we have a weather that varies from region to region. This is why Colombia is one of the most exuberant countries on the planet. Our diversity is also reflected in our population. We have more than 60 languages and several ethnic groups, such as indigenous ethnic groups that account for more than 100 Afro-descendant and Roma populations. This wealth in natural and human resources was pictured by one of the most illustrious Colombians, the Nobel laureate Gabriel Garcia Marquez. I strongly recommend to read his work so you will be able to understand the wonderful, magical realism that we carry in our Latin American blood. Sadly, not everything in this description is positive. We are one of the most unequal countries in the world. Few are rich, very rich, and many are poor. We also are one of the countries with the highest administrative corruption. This is why we easily became one of the largest producers of narcotics, which has been the cause of the worst stigma that accompanies us. Among the characteristics that frame the economic conditions of a country are the demographic figures. Of these, one that might interest this audience are pregnancies in underage women. In my country, 1 out of 5 women under the age of 18 is or has been pregnant. In Colombia, more than half of pregnancies are unplanned, and among the underage group, none of the pregnancies are wanted. Despite that, access to contraceptive therapies have improved over the last years, we still have a long way to go, especially regarding sexual health education. The great negative impact of these problems on the population with low level of education is evident. Here, I would like to introduce the why of our research. It is quite simple, and I will summarize it in 2 points. First, unwanted pregnancies, especially in young people. And second, acne. Regarding unwanted pregnancies, causes are multiple and consequences are large. Speaking of causes, I would like to mention one in particular: the low adherence to modern and effective contraceptive therapies. Regarding consequences, I would like to highlight the limited opportunities to achieve a good and stable future. In many cases, an unplanned pregnancy makes young people more likely to quit studies. Without a degree, it is almost impossible to get a good paying job. This way, it is complex to stop being poor. Since I developed my work at an educational institution, I have seen many young people dropping out of school because of an unplanned pregnancy. The second point is acne, a cutaneous disease highly prevalent globally in young people, up to 80%. A disease that, besides injuring the skin, also leads to significant mental health problems, especially to teenagers and young people. Now you can understand what we are looking for, showing the non-contraceptive benefit of reducing acne, an important argument to improve adherence to contraceptives. To date, this is the first time that a study of these characteristics has been carried out in the Colombian population, and the first in the world using a combination of Dianogest and 20 micrograms of ethinyl estradiol. Now I will present the results. This study sought to measure the benefit of combined oral contraceptive therapy in acne, at concentrations which had not been studied in real-life conditions. Since acne is a disease of high prevalence and with a strong impact on the mental health of young people, this non-contraceptive benefit can be used as a treatment strategy for acne. And at the same time, improving acne is encouraging to increase the adherence to contraceptive therapy. University students who started this contraceptive therapy and had mild to moderate acne were invited to participate in a follow-up study for 12 months. Each month, the contraceptive use was checked and the number of acne facial lesions was checked. An observational study was performed, following a cohort of female students between 18 and 30 years of age with a diagnosis of mild to moderate acne, whose physician prescribed treatment was ethinyl estradiol 20 micrograms and Dianogest 2 milligrams as a birth control method. These women attended the Sexual and Reproductive Health Program of the Santiago de Cali University. The sample was calculated considering a decreased percentage of total facial acne lesions of 15%, accuracy of the estimate of 95%, a 95% confidence, and a percentage of loss to follow-up of 20%. In this way, a final sample of 121 women was obtained. Reduction in acne lesions was evaluated using absolute and relative changes in facial lesion count of comedones, papules, pustules, and nodules, and the sum of these at 6 and 12 months of follow-up. A total of 120 women with acne were recruited, and the percentage of non-participation was 12.4%. Follow-up median was 9 months, interquartile range 3 to 10. The percentage of loss to follow-up was 34.2% at 12 months. Most losses were voluntary retirements not related to any adverse events. The median age of the study population was 21 years, interquartile range of 19 to 22. Regarding epidemiological and clinical characteristics that can affect the presence of acne lesions, it was found that 39% of participants were Afro-descendants. 21% used non-prescribed topical presentations of acne. 12.5% had a history of estrogenic disease, and 22.5% had a history of smoking. In addition, median weight was 57 kilograms, height 1.6 meters, and body mass index 22.2 kilograms per meter squared. About 50% of women were diagnosed with 52 or more lesions at baseline, while at 6 months the range of lesions was between 6 and 27, and 4 to 29 lesions in the last month of follow-up. The reduction in lesion counts appeared early in the follow-up. A reduction in the median was observed between startup and the first month. After 6 months of follow-up, it was observed that no substantial changes in the median of lesions were presented, and it remained at low levels as those achieved in the first semester. At the end of follow-up, of the 79 women who attended, 23% reduced all of the acne lesions. In 48% of women, lesions were reduced by 90 to 99%. And in the remaining 28%, acne lesions were reduced by 50 to 89%. In a bivariate analysis, we found that the median relative difference in total acne lesions at 6 and 12 months of follow-up was greater than 80% for all groups. In the 6th month, the median relative difference was greater in women with no family history of acne compared to those with such a history, while at the end of follow-up, the median relative difference was greater in non-African descendant women compared to that in African descendant. In addition, the data suggests that in women with no history of polycystic ovary, and in those with body mass index of 20 kilograms per meter squared, median relative difference was greater, and the findings were not statistically significant. Regarding the adverse side effects, 24 women, 20%, reported adverse events. 8 had headaches, 15 women reported small breakthrough bleeding, spotting, and 1 woman reported weight gain. This study showed statistically significant reductions in clinical symptoms regarding facial lesions of mild to moderate acne in women between 18 and 30 years old. The results were 92% and 94% of lesion reduction at 6 months and at the end of follow-up, respectively. Finally, 23% of women completed the follow-up without lesions. According to the guidelines for the management of acne vulgaris of the American Academy of Dermatology and the European Guide for the Management of Acne, oral contraceptives are part of alternative treatment for women combined with other medicines for moderate acne, including papulopustular acne. However, this study shows evidence that women's oral contraceptive ethinyl estradiol 20 micrograms with Dianogest 2 milligrams may be considered as first-line treatment of mild and moderate comedonian and papulopustular acne. We hope this acne reduction side effect becomes an additional incentive to motivate young people to continue using the contraceptive. Looking forward to hearing your comments. If you have any further questions, you can keep in touch with me on email. Thank you.